himself and just like your background, that would be super great. So I'm going to turn the floor over to you to introduce yourself. And while you're doing that, I'm going to hit record. Hi, Doug.
Hi, Andrea. Thanks for having me, and good to be here. And my name is Doug Wolfberg. I am a lawyer, but I please ask that you not hold that fact against me. I am with the law firm of Page, Wolfberg, and Worth, and one way or another, I've been in EMS for 40 years. I hate to say how many years. But I was a field provider, a county EMS director, regional EMS director, worked at the state EMS level in Pennsylvania, federal EMS programs for a while, and then went to law school. So we just represent EMS agencies, and I do a lot of work along these lines too with documentation skills, and happy to be here. So thanks for having me.
Thanks, Doug. Thanks for joining us. So with that, I'm going to add my disclaimer. I think that's quite timely. So the Michigan Center for Rural Health is not offering legal advice or consultation, but we might have someone joining us that could, hint, hint. Please consult an EMS law expert with legal and compliance questions. So obviously I am not an attorney and I won't be offering any of that advice, but we are going to hit it hard with just the concepts behind clinical documentation. And I'm going to share with you a little bit about what I've learned during my career. And then Doug is going to share all of his expertise with us this evening as well. So in opening it up, I put together this diagram. I kind of sat down and thought about, what does clinical documentation mean to me? And after reading a lot of research, lots of articles on EMS1 and GEMS and digging deep, this is what I came up with personally when it comes to just the effects. So the first thing is, with poor clinical documentation, some of the things we might run into: decreased revenue for your agency, increased liability in relationship to your agency. We also can make our patients vulnerable, which I'm going to get into a little bit, and we'll talk about that. And then also a negative industry image. So we're going to kind of touch on this throughout the presentation. So I'm just going to introduce this diagram to you, take a peek at it, start thinking about it, and we're going to hit these as we move through, and then we're going to circle back and we're going to revisit this diagram. So poor clinical documentation, what can it do? Well, it can leave our patients and our agencies vulnerable, okay? So just imagine this, you're out in the streets, you're super busy, you're doing your documentation from call to call, and maybe you're the provider that's starting to leave out details, and maybe you've kind of forgotten some of the ins and outs of clinical documentation, and billing is not able to bill for certain services. Over time, what's going to happen is, if those interventions aren't documented, we can't charge for those, right? If you don't document the details of the call and whether or not medical necessity was there, which we're going to get into, we also might not be able to bill for that. So what happens to our patients when we're not able to bill for all the services? They end up getting some of that financial burden, and so do we. So this kind of has a double whammy impact, and we're going to see that as we move through the presentation. So I always want everybody to keep that in mind when we think about clinical documentation, is there is a financial aspect to it. And oftentimes I hear from my colleagues, oh, well, you're just, you're trying to get some extra money, and it's just so people upstairs can get those bonuses. But there's so much more to that story. And so that's one of the reasons I'm really passionate about this, is when you get into billing and you get into revenue cycle management and you look at this, there's just so much more there. And it really truly impacts the agency, all the way down to what kind of monitor you have in the back of your ambulance. So purposes of clinical documentation. So we've got a clinical record, which also impacts continuum of care. And what I mean by that is, when you record your clinical record and you send it off to the hospital, as you already know, the physicians are able to tap into those records, the nurses are able to look at those. And without that continuum of care by your verbal report, as well as your clinical documentation, that continuum of care can actually be disrupted. So this is a really important aspect of clinical documentation. And then the legal facts, what happened? Those facts are right there, right? And there's the old saying, if you didn't document it, it didn't happen, right? So we just want to be very clear on what exactly happened. We want to include what we saw, what we heard, what we smelled, what we tasted. Well, maybe not, hopefully not. But all of those details we want to include, and we want to lay out the facts of the call, and the narrative is really where that's at. The drop downs cover some of it, but our narrative is where the bread and butter is. And if you notice, when you do get reports kicked back to you, oftentimes it is related to your narrative. It's not often related to a drop down box. Then we've got operational data. As we start to grow and evolve as an industry, and we're looking at things like NEMSIS versions, and we're looking at workforce data, we're also looking at clinical data. What we're entering into these reports is going to not only have a local impact, it will have a state impact, and it will have a national impact. We're going to be relying on data more and more as an industry, and we're going to be able to pull that data. So this is really exciting. So again, it's important that we don't select the wrong dropdown, and it's important that we put keywords in our narrative so they can get pulled and used for data. And then the financial aspect of it. If you can't bill, essentially you're not going to bring in any revenue. And I think the last thing any of us want to do is go on a call, work really hard, send off documentation that's not quite up to par, and really essentially provide a free service. As much as we like to do community service, especially in this day and time, we know that we're hurting financially as an industry. And so this is a really important aspect of that. And the other that I mentioned earlier is leaving our patients vulnerable. We have to keep in mind our patients are relying on us to be able to submit a claim and get it paid. So we do have a duty to submit good clinical documentation for our patients as well. And then of course, compliance. Are you in compliance with the local, state, and federal laws? There are drop downs specifically designed for that. And so it's really important that we are keeping that in mind as we move through our documentation. So I've got a lot of print on this slide. I'm not going to stand here and read this all to you, but I wanted to bring up medical necessity. And I'm glad Doug is here tonight because we have a lot of, I think, misconceptions, things that we spread around about medical necessity. And one of the things that I found really interesting in doing my research is what's at the bottom of this slide. So it says for 2020, and I took this from CMS, for the 2020 reporting period, insufficient documentation accounted for 62.5% of improper payments for ambulance services. Additional types of errors for ambulance services in 2020 reporting period were medical necessity at 23.5% and incorrect coding at 10.8%. So those percentages are quite high. And when you look at that, you go, wow, that is really interesting that we are really missing the mark that often when it comes to just what CMS is looking at. So medical necessity essentially is, could they have went any other way? Is there another way that this patient could have went outside of ambulance transport? And you can read the definitions I have up on the screen to be thorough, but that's essentially what it means. Can you justify the ambulance transport? So I purposely scoured the internet for a PCS form because I wanted to remind us what these look like. And we know that all PCSs don't look exactly the same, but they're all very similar. So the first question up here that I have highlighted is this patient bed confined, yes or no? And then they go and list all of the things that make someone bed confined. Then it says, can this patient safely be transported by car or wheelchair van? So we talk a lot about this when we're documenting, right? We'll go on a call, we'll do an interfacility transport, and we'll say, man, that patient was up hip hopping and walking around, took him to the bathrooms, totally fine. I wonder if we're going to get paid for this, right? So that's a question that's always floating around with crews is, well, the PCS says they're non-ambulatory, but they're up walking around. So it's a really interesting dichotomy with these forms. And then the last piece of the form is all of the indications that you can check as the physician that's sending the patient out as to why it's medically necessary from the physician certification standpoint to send this patient out. So because I'm not really the expert here, I would love to pick Doug's brain on this. So what happens, Doug, when you have a patient that you go pick up and the PCS says, for example, that they're bed confined or there's something alluding to that, and there may be some boxes checked, but then you get there and the patient is truly ambulatory and you worry because your PCS isn't going to match your PCS isn't going to match your run report. How does that billing process play out for our crews on the back end?
Well, I know this will come as a galloping shock to everybody who's watching and listening tonight, but sometimes nursing facilities and other facilities will say whatever they need to say to get you to bring the ambulance. Oh yeah, they're bed confined, and you walk into room 116 at the reported time that you're supposed to pick up the patient, and they come ambling out of the restroom and plop down on the stretcher, and okay, I'm ready, and you're looking at that PCS going, dude, you're not supposed to be able to do that, right? So yeah, that's a common thing. And Medicare will hold that against ambulance services. They'll say, well, your PCR was inconsistent with the PCS. To which, we say, well, go talk to the people at the facility that wrote this bogus PCS, right? So look, the bottom line is EMS practitioners should not be writing a PCR just to make it coincide with what somebody said on the PCS if we know that to be inaccurate, right? If they check the box that says bed confined and we see the patient seated in a chair or ambulating unassisted to the stretcher, they're not bed confined. So we can't write that they are just because that's what the PCS said. What we really have to do is go back and work with those facilities really through our billing office, through our compliance officer. We don't really suggest that the crew gets into a back and forth with the nurse at the facility at the time. Well, this isn't, you give us something that's accurate. That back and forth at the time of the transport is really usually not the most fruitful time to do that. But these facilities really have to understand that they have a legal obligation to make sure that their medical records are accurate, and a PCS is a medical record. And the government has gone after facilities for having inaccurate PCSs. So, at the end of the day, our advice is that the crew has to document what they've seen, what they've observed, what they've done, what the patient's condition is. And if there are just glaring inaccuracies in the PCS, that shouldn't color what we do on our PCRs. But those do have to be resolved, and it should be handled on a compliance level with the facility is usually what we recommend.
Excellent. Yeah, thank you. That's wonderful advice, and thanks for that clarification. I think that's one of the burning questions we have out there is what happens when we take this patient and provide them great care. So great. So I also pulled some literature from CMS around medical necessity. And again, a busy slide, and it's not here to read to you, right? So I didn't put this up. I'm not going to read this all to you. But oftentimes, we have these conversations of, well, what's going to be reimbursed and what's not, and what are the guidelines? And so I thought that this was really interesting. If you've never really looked at some of the CMS guidelines or Medicare guidelines, and you've never really looked at what they have out there, you can find this, by the way, all on the web. So this is available to you. You can Google all of this, but I wanted to put this up there just to kind of illustrate some of these points. Like the very last one, the patient was bed confined before and after the ambulance trip. That's a common one. The patient could be moved by stretcher, another common one. And then you've got, specific wording in here around some of these injuries and illnesses. And I think words are key here as well. So when we look at these words, it can be quite telling. So I just wanted to put this up. We won't spend a lot of time on this, but maybe this will generate some thought and some questions behind some of the other concepts we're going to talk about. So the impact of the ePCR. So obviously, medical necessity is determined primarily by your ePCR. And again, I can't hammer home how important the narrative is. And again, how our billers really rely on those narratives. That's their first go-to is our narrative. And we're going to walk through some narratives, and I'm going to outline some of the things that I've seen. I did personally pull some of these from my career. I did work as a soup for quite some time, and part of my job was looking at the narratives and filling the gaps when it came to getting with crews and adding addendums or clarifying something. And it's really interesting when you see how some folks have written certain types of narratives for years and years and years, and others have just shined in that space, and how you can have such a dichotomy and difference between one narrative to the other. So if the auditor finds the clinical documentation incomplete or vague, they may just decide not to pay it, right? We don't know what happened on this call. We can't determine whether the patient needed to go by ambulance. There's just not enough information there. Well, who's going to get stuck with that bill? The bill may go directly to the patient as a last resort. This is not a good outcome for the EMS agency nor the patient, right? Because the patient, it might be such a large bill they can't pay it. They may be on Medicaid or have some hardships they're facing and not be able to pay it. And either way, that agency may not get paid for service. So you've got a vulnerable patient that's unhappy with their service because they are going to be unhappy if they get a large bill after suffering a medical emergency. And then you've got the loss of revenue on the EMS agency end. So this is all very important to bring together and highlight. And this is really our why. This is why we need to do good clinical documentation. So next up, patient signatures, right? And I really wanted to find, a meme or something with, somebody, a supervisor or somebody chasing around a crew member, but I didn't want to take it to another level. But that's what I think of when I think of signatures. Got to get that signature, make sure you get that signature. And during COVID-19, there were all kinds of talk, right, about, well, I'm not handing over my pen, and is this clean? What are you going to do with a vented patient? Are you really going to get them to sign? What are you going to do with the trauma patient that's full of blood? All of those things. So the reason we really need these signatures on so this form should look familiar to you. Again, slight variations, but I pulled an AOB from the internet. And the AOB is really called the assignment of benefits. And the reason there's slight variations is some companies put like a HIPAA privacy statement in there on their AOB, some don't. But what the AOB allows for is claim submission. And don't just think of it on behalf of the EMS agency, right? Because we're advocating for the patient there. We want to get it paid. Continuum of care in the sense that you can share protected health information with the facility as you drop the patient off. The privacy statement, HIPAA, and financial responsibility. The patient is looking at this form. And again, I always sympathize with the patient when they're not feeling well. And I slap this big form in front of their face with like a big paragraph of HIPAA, big paragraph of I accept financial responsibility. And they say, I can't read all of this right now. And we need to break it down, and they need to trust us to sign it. And what we notice is that most patients do, right? We have that trust with them, and they trust that they know what they're signing, and generally they sign for it. So Doug, who is authorized to sign the AOB? Because oftentimes we find that the patient can't sign, and then, we need to get a representative. So who is authorized to sign the assignment of benefits form?
Well, before I answer that, I want to emphasize something you embedded in your question that is very important, and that is that you can't move on to get the signature of any representative of the patient unless first you determine that the patient is mentally or physically incapable of signing. And that is different, of course, than a patient who simply doesn't want to sign. I don't want to sign that. Get my wife to sign it, right? That's not the same as being incapable. So it's these rules that allow you to move on to get the signature of an authorized signer on behalf of the patient only apply when the patient can't sign and that you document the reason why. So that was something that you stated very adeptly in your question, Andrea, but I think that's worth noting. So the people who can sign when the patient is physically or mentally incapable really include the people who you see listed on the right side of this form, which our firm put together. This is a variation of our form, it looks like, but that has the authorized signers listed. It's that section 2 of that form. So it's the patient's legal guardian, right? Somebody who's usually like court appointed, a healthcare POA, a power of attorney, or it can be somebody who isn't a formal POA, but helps take care of the patient, a neighbor who comes over and checks on them, right? A family member who's not necessarily POA, but helps take care of the patient. It can be somebody at a facility that provides care or services to the patient, a social services agency that provides services to the patient. So there's a list of authorized signers, but it's important to remember none of those come into play unless first you've made a determination and documented it that the patient was physically or mentally incapable of signing. Oh, and one other thing, we can't just say patient unable to sign, or sometimes phoning that in, we just say PUTS. We need the documentation of the reason that they are incapable of signing. Then you can move on to those authorized signers. Last thing is that during the pandemic, during the COVID-19 public health emergency, CMS did allow for an exception only during this period of time uh, to cover the scenario that Andrea mentioned about, well, we don't want to hand over our ePCR tablet to a potentially contaminated patient. Just during the pandemic, if there is a potential COVID patient, the crew can sign. Normally, crew members cannot sign for the patient, but the crew can sign if the patient verbally instructs the crew to do so. So that rule is specifically to reduce the chance of cross-contamination of ePCR devices only during the pandemic and only for those patients who we believe are potential COVID patients. So that is the only narrow exception, and that's going to go away once the pandemic is declared over, which, knock on wood, we might be getting, close to.
Great. Yeah. And so I kind of I happen to fall into another burning question. So with this form, there have been a few times during my career where the patient asks me, so it says the patient must sign here unless the patient's physically or mentally incapable. And then it says if the patient signs with an X or other mark, someone should sign below as a witness. So I've had patients that just couldn't see, and they were like, I would tell them like, hey, you can, if you want, you can put the X there. It says that, and I will sign for you. But is there any liability behind that? If the patient says, okay, I'm just going to put an X and I sign below, is that as good as the patient's signature? Can we go to claim submission with that?
Yeah, the signature there of the crew is, or it can be any adult really. All we're doing is witnessing that yes, it was the patient who put this pen in their hand and made that mark, because it's an X or it's something that really doesn't look like a signature. So we're just attesting to the fact that it was the patient's mark. So we really don't take on any personal liability. If you witness a patient signing by mark, you don't become financially responsible for their bill or anything like that. And we've not had a case where that has failed on audit. So in that case, we have a patient who is capable of signing, but maybe for some limitation. Could also be illiteracy. I mean, we've seen other reasons where they just make a mark. And if the crew just attests to that, that's really all they're doing. So that's really kind of a low risk situation when we witness that type of signature by mark.
Okay, great. Thanks. Yeah, thanks for that clarification. I've always wondered because that has happened to me.
Sure.
Andrea, there was a question in the chat box that says, what do you do about those patients that refuse?
Sorry, I was muted. Does that mean refuse to sign? I think Doug covered that just a little bit.
Okay.
So
I can fill in my answer on that. All I said was that it wasn't the same as being incapable. If they refuse, you should document that it wasn't that they couldn't sign, it was just that they refused to sign your AOB. And then what the biller will do when they see that is they're going to send the patient a bill. And because without that authorization, we can't submit the claim. So what usually happens then, in case anybody's interested, is the billing office sends the signature form to the patient with a copy of the bill. And basically it says, you can sign this signature form or you can sign a check in this amount, and the patient will often think better of their decision to refuse to sign, and they'll send the signed form back and then we file the claim. But they get the bill if they refuse to sign the AOB.
awesome. Thanks, Doug. Yeah, and I saw the other question about PowerPoints and recording. Both will be available after. And if you have some in-depth questions about our website after, I can go over that with you guys at the end. So great questions. Thank you. Okay, so let's explore ePCR some more. So popular narrative formats, we've got our SOAP, we've got our DRAATT, and we've got our DCHART, right? So I'm just going to walk you briefly through these. So SOAP is the subjective complaint, the objective findings, the assessment notes, and plan of action. So that's what SOAP stands for. I'm going to move down to DCHART. So DCHART is dispatch, complaint, history, assessment, treatment, and transport. I used that quite a bit early in my career, and then I worked for another agency that used DRAATT. So DRAATT stands for dispatch, and then R is response, A is arrival, and the other A is assessment, And then the 2 T's are treatment and transport. So Doug, can you tell us a little bit about DRAATT? And you had some creative reign behind DRAATT, didn't you?
Yeah, DRAATT was a creature of my restless imagination. So we did develop DRAATT as part of the CADS, Certified Ambulance Documentation Specialist program, which we will be bringing to your neighborhood in October. Is that what it was?
So I was wrong. I was thinking October. It's September.
September, even better.
Yep, early September.
Yeah. So DRAATT, and when we sat down to come up with DRAATT, I've taken tens of thousands of ambulance calls in my life when I was in the field, and I really just sat down and thought about a chronological evolution of a call, right? Because our brains as humans, we process stories from the time we're kids. It's imprinted that we go from once upon a time to happily ever after, right? And not every EMS calls happily ever after. But the point is that we process stories chronologically. And when a story is told out of sequence, it becomes disjointed, it becomes difficult to process, and it can raise questions, particularly when we're a very protocol-driven profession. So the DRAATT format, dispatch, response, arrival, assessment, treatment, and transport, is really meant to flow chronologically, not just with, patient assessment like SOAP and treatment like chart, but it's really to follow the whole chronological evolution of that call. So that was, when we looked at those other formats, which we've used for years and have been standard, we thought it's time to put a new standard out there. So we developed that really just to be a chronologically based narrative writing format to process narratives the same way our brains process stories. And that's what a narrative is at the end of the day. So that's a little bit about the thought process when I sat down at the computer and went, we need a new format in this profession. And that's where it came from.
Very cool. Yeah, I didn't know that you guys were behind the DRAATT, so I learned something new there. That's neat. And I have been using DRAATT for the last couple of years, and I don't know about you guys out there, but when I'm writing my narratives, I do use the mnemonic. I will sit in a truck, especially if it's 3 a.m. and I'm not functioning well, and go, did I get D? Did I get R? Did I get A? And it really helps me along to make sure that I don't end up with some negative feedback and also some missing information. So I really enjoy the mnemonics. I think they help us quite a bit. And I really do enjoy the DRAATT format personally. So let's look at narrative example number 1. Now, I didn't do this just to be dramatic. So yes, I picked it probably for a little drama, but I'm going to tell you, I have worked with folks that this is their narrative. And trying to back someone out of this who has done this for 15 or 20 years can be extremely challenging. And kudos to you, because man, I mean, that's you're saving a bunch of time, right? But are we going to get paid? Is the patient going to be financially liable for this? This is the biggest concern here. So this is example number 1. So Alpha 1 responds to the above address for a 65-year-old male patient found on the floor. Patient assisted to his chair, no injuries found. Patient refuses transport, end report. So, there's so much information missing here, right? How did you respond? Were you emergent? Did you use lights and sirens? Did you not? What was the patient's complaint? It just says he was on the floor and says he has no injuries. So is this a lift assist? How did he fall? Where was he on the floor? I mean, there's so many aspects of this. So when you read this, the first thing that I think of is, I have no idea what happened on this call, really, aside from someone was on the floor and they were assisted to a chair. There's no medical history. There's no assessment documented in the narrative. And I think it can be really challenging for folks to go along with. I often received a lot of pushback from crews that would say, I already checked all the boxes in the assessment. Why do I have to put it in my narrative? That is just repetitive. And there's a couple reasons for this. The first is the billing department goes to the narrative, they look for the assessment. The other part of that is it really does create a flow, like Doug was saying. You are getting the whole story. You're getting all of it in the story as you move through the chronology of the story. And it really makes your reports flow nicely. If you can look at a good assessment and go, oh, the GCS was 10. when you're reading a report versus, you know, what are you going to do? Go back through and flip through the report to look for the GCS to put the story together. It just doesn't work. And I think oftentimes our personnel really struggle with that. You're creating extra work for me. I shouldn't have to do this. And the why behind that, the story behind that is a chronological flow that is relied on by billing. It's relied on by the physician in the ER. The first thing they do is look for our narrative and they read it. And if it's not in that narrative, they are not often, unless they've worked as an EMT or paramedic, they're not going to go searching through our drop-down boxes. They don't understand all of that. And it's time consuming, to be frank. So there's a lot of reasons why we need to put all of these elements into these narratives. You know, treatment, what was done for the patient? I mean, it sounds like nothing, but again, did we really cover this? No, we just put the patient back in the chair. And then I will tip my hat to, okay, we did a pretty good job of saying we didn't transport, right? So we know that this was not a transport, but there's so much missing information here that this is a liability, a legal liability. This is on the losing end of reimbursement, not only for the agency, but for the patient. And it all is going to wrap up into a organizational culture that we're going to talk about as well. So before we move on, Doug, any notes about this before I go on to the next narrative?
So I don't want to monopolize your time because I could talk about patient refusals, you know, for a couple of hours.
We're getting there, and I can't wait to hear about it. But yeah, if you want to add something here, no, this.
No,
this
I'll wait then.
Bars,
I'll wait till we come back to the topic of refusals. That's right. I forgot you had another slide on that. So nothing to add right now, but you're nailing it. You're saying everything I would say. It's great.
Oh, great. Thank
you. You have another question in the Q&A that says, can you write too much information in a narrative?
Yeah, so, okay, well, I'll go first. I'll definitely let, I want to hear what Doug's response is, but thank you for the question. And yes, I'm going to answer that one live. So can you write too much information? Yes. Have I seen that as an administrator, soup, director, you know, whatever role I played? Yes. Is it often the case? No. And the reason for that is the amount of time, right, that's invested. So oftentimes crews just don't have that much time, but I have seen it a few times during my career. I had an employee that was writing 3-page narratives, and it would just continue and continue and continue. And I do believe that there is a downside. We did talk about it a little bit. There was some counseling that went on, but again, very carefully counseling that because, wow, that's amazing, right? You're that passionate and you want to provide that much detail. And I think that's incredible. But the backside of that is, again, billing is going to have to do a little bit more legwork to kind of sift through all of this additional information. I also would worry about the provider getting burned out, because if you're in a busy system and you're doing that, boy, you're going to get burned out very quickly. And again, from a reimbursement standpoint, there just might be too much to sift through where billing could miss some of those items. So yes, I've seen it. Yes, can you take it too far? Often, yes. And it's usually with extraneous detail. It's not your assessment's too long. You can't really go wrong there. It's the extraneous detail that was in there that didn't need to be in there. Doug, anything to add to that question?
No, that was a perfect answer. That was great.
Thanks. Okay. So great question too. What an excellent question. So the next example is kind of along the same spectrum, a little dramatic here, but again, I've seen a lot of these. So, you know, Alpha Run, so this is an interfacility transport. So Alpha 1 responds priority 7 to ABC Hospital, bed 2 for an 88-year-old female being transported to DEF Hospital for a higher level of care. Patient is unable to stand or sit and complains of chronic pain. Patient sheet slid to our cot and secured, patient transported to DEF Hospital, and sheet slid to her bed without incident, end report. So again, a lot of missing information here. Okay, fine, you might know what your priority is, right? But remember, a biller, especially someone in CMS that's looking at this as well, someone outside of your agency looks at this, they don't know what a priority 7 is often, right? So are you emergent? Are you non-emergent? Is this an interfacility? What type of call is this? What else are we missing here? So we've got our complaint. Well, complaints of chronic pain. Okay, where's the pain? What's the medical history behind the pain? What's the history behind the reason for transport? It says a higher level of care. What does that mean? Why is the patient being transported? And then, you're alluding to a non-ambulatory patient because you're saying their sheet slid, but you're kind of riding a gray area there. There's no assessment information. There's no treatment information. So was there oxygen placed on the patient? What kind of assessment was it? Was it an advanced life support BLS assessment? Where are we there? And then how were they transported? Non-emergent, emergent, to what facility? To what bed, to what wing, to what nurse? All of those little tidbits of information are missing as well. So we've got a lot of clinical information missing and a lot of logistics missing from this run report. And really, medical necessity, it's not there. Complaining of chronic pain, unable to sit and stand, you haven't really nailed that at all. There needs to be more information. So again, a lot of missing information with this narrative. Before we move on from this one, Doug, anything to add?
Nope. Once again, you covered it well.
So what do we want to capture? And I've kind of already went over this, so I won't spend a lot of time on this slide, but we just want to be sure we paint that picture, right? So chronologically, what happened on the call, and they always say your grandma should be able to read your run report. You should be able to take your run report home, put it on the kitchen table. Grandma should be able to read it and go, oh, you did this today with this patient. So when we say that, what we mean is it's not filled with a lot of abbreviations that a biller or coder wouldn't know. And we understand that there are approved abbreviations for each agency, and your billing, will know that. But the less of these abbreviations you use, the better. And that is just from a reimbursement standpoint. So again, the abbreviations, the sights, the smells, what really happened on the call. We just looked at 2 examples where we really didn't paint any kind of picture. We could, allude that it was a refusal. We could allude that it was an interfacility transport, but we don't know the why behind any of the calls that we just went over. We could only allude to it. So really taking that and painting the picture and creating a story that someone can read and draw from. That's what we want with our narrative. So excellent examples of narratives. I do have 2 web links. I don't generally do this on presentations, so I'm going to try it and see if it works for me. And if it doesn't, I'm just going to apologize. So let's see what happens. Can you all see this? Yes or no?
No.
Can you see this?
Yep.
Awesome. Okay, thanks, Victoria. So this is one of the examples that I pulled. This is the DRAATT scenario. And this is what I pulled an example from the internet. And this takes you through what a DRAATT outline would look like. So you've got your chief complaint outlined here, your history, your assessment. They went through all of the details. I'm assuming some of this was probably pulled from the software platform that's being used and dropped into the narrative as well. And then treatments, secondary assessment, and transport. And so you can see at what level and detail this crew member went with this DRAATT format. This is vastly different than the 2 narratives I just showed you. So I wanted to highlight this because this is a really great example showing how an ePCR system and a DRAATT format can come together and how thorough it can be when it's finished. So I'm going to stop sharing this one and go back to my slides. So the chart and SOAP, I'm going to go ahead and just move on from in the interest of time, but this also is a live web link. And when you get into the slides, you can click on this link, and it's a really great example of chart and SOAP. It looks very similar to the example I just showed you. So hopefully getting an idea of what our narratives are really going for. So one of my favorite topics, refusals and no patient found calls. And there's lots of stories that float around about the refusal that went wrong, the no patient found call that went wrong. And it all comes back to what was documented, right? So the example that comes to mind first is no patient found. There was a case where an ambulance crew went on a call for someone in a car, and They looked around, didn't find the patient, and then I can't remember all the details, but there wasn't a lot documented. I believe all they documented was no patient found in their ePCR. Later, they discovered that there was a patient in a car that had passed away. I believe it was an overdose of some sorts, and someone had called. They knew they were in a car. I can't remember all the details, but the point is when you document, so for example, when you go on a no patient found call and you document no patient found and you send off that ePCR, that is setting you up for quite a bit of liability. And what I mean by that is you should be documented what you did, right? Like how many times have we went on a medical alarm alert, doors open, we enter the home, search the entire home from top to bottom, and connect with the neighbors, talk with the neighbors, and we get in the truck and write no patient found, right? Well, what if we missed that patient and they were having a medical emergency and we did not write in our ePCR narrative, searched all levels of the house, no sign of patient, searched all levels of the basement. I mean, these things are things we really should be documenting. And so it really makes me nervous when I hear that crews aren't doing that, because really it just sets you up for liability. If that patient is found later, which there have been cases of that, they will come back to your narrative. And if all it says is no patient found and there's nothing documented about you searching the area or searching for the car, it really can be a liability, not only for you, but for the agency as a whole. So with that, Doug, what would you say are the liabilities associated with refusal calls and no patient found calls?
Yeah, so I think the biggest thing is that I think too many EMS practitioners put too much faith in the magic power of signatures, thinking that if they get the refusal form signed by the patient or their legal decision maker, that they're good, because that's got all the legal language in it. I hereby release the EMS providers, the ambulance service, the medical command facility, and the mailman and your third cousin from any and all liability. But the reality is that a signature without a narrative is really just an autograph. It's no protection at all. Because the questions that will come up is, was the patient competent to make that decision to refuse? Did you do a sufficient assessment that you were able to tell them what you thought the problems were and why it was important for them to get treatment? Because if a patient thinks there's no consequence to refusing, the refusal decision is meaningless. The signature is meaningless. There's no protection if the patient didn't know what they were signing. So the real protection comes from a thorough narrative that makes it clear we assessed the patient, we gave them, in plain English, a description of what we thought the problem was and what we proposed to do about it, why it was important they go to the hospital and accept the treatment that we're offering, what they should do if the symptoms get worse or don't get better, give them instructions if they're going to refuse, show that we advocated for the patient, right? That we really did everything we could to convince them to get care. Now, if you do all of that in a narrative and get a signature, I'll go to court on your behalf, every day of the week and twice on Monday mornings. But the fact is if all you have is the signature and not that good narrative, you really have no protection. And there are just case after case after case where courts throw out the refusal forms and they throw out the waiver of liability that comes with those refusal forms because the evidence suggests the patient really did not have an understanding of the risks of refusing and the benefits of accepting care. And that's what the documentation has to reflect. That's what the protection, where the protection comes from.
Excellent. Yeah, great perspective. So yeah, don't cut your corners with those refusals, and do some great narratives and thoughts with your ePCRs with these calls, because really they are definitely one of our higher risk narratives, at least in my opinion. So the 3Ds in documentation. So I wanted to bring this up just because there's one aspect of this that I wanted to touch on. So the 3Ds are obviously document completely, honestly, and timely. And so timely really stands out for me. And the reason I want to just briefly touch on this is timeliness is really important. Having worked in many rural systems, I've worked in systems where, providers are, they come back to the station, they end up going to bed. Maybe it was a run in the middle of the night, wake up to another run, then they're off, they go home, they never complete that ePCR. And 3 days later, they're working on their ePCR. This can be a big problem. And it can be a big problem because it's interrupting the continuum of care. So you may have given a great report at the hospital, but that report does not replace your narrative. And when that physician that may not have even met you goes back to look for your report and it's not there, it's going to be disappointing. The other thing that I want to highlight is, often a good reminder of how important it is to write your narratives right away is get into a busy system and get backed up by 5, 6, 7 reports, and then try remembering the details of every single call. It can get incredibly confusing. It can really strap you when it comes to liability because you may be getting 2 patients confused and you're stressed and you want to get these reports done. So timeliness is really important, and systems that allow their providers the time to sit down and do their reports generally have better quality reports. And you can take that and do with it what you will, but those systems have happier providers because those providers can complete the call all the way through. They are not stressed getting into a truck, trying to finish a report on the way to another call. They are dropping the patient off, going into a crew lounge, writing those details down. They might not get their report completely finished, but they've got their narrative outlined. So when they move on to that next call, they are not getting so backed up that they're becoming stressed and they're feeling the burn. If you do that to someone day after day, clinical quality is going to suffer and your timeliness might not be great as well. So whether you're in an urban, suburban, or rural system, we're all traversing different challenges. But this timeliness factor relates directly back to culture and how the work environment is set up. And those 2 things need to be aligned for your providers to be successful with a timely submission that's also accurate. So that timeliness I wanted to touch on because I think it's a really important aspect of what we do. And oftentimes we miss that when we start looking at clinical documentation. So let's say we go back to narrative 1 and we find Bob. Bob wrote narrative 1. And we want to talk to Bob because we want to improve clinical documentation for our agency. And we're noticing that we're investing a lot of man hours into following up on Bob's reports in the hopes that we are securing payment for the patient as well as the agency. So Bob doesn't understand why he's being counseled. Bob's been working for ABC Ambulance for 20 years. He's always done this way. No one's ever talked to him about this. Why are you approaching me? I don't need to change this. What are you going to do? You're going to fire me? What are you going to do? Right? So how do we handle a situation like this? And when we get into a situation like this, where we are, boots on the ground running, and we want to improve clinical documentation, we want to not only improve it for revenue, right? But we want to improve it for our patients. We want to protect our customers. Of course, we want the revenue. We want that life packer, that Zoll monitor. We want those things. We want that pay increase. We want the boot stipend, all of the things that come along with the boosted revenue. So one of the things I wanted to bring up was culture and how culture can really impact how your providers are viewing the ePCR. So culture starts with your values, and agencies often have mission statements and value statements, and you can write it and you can live it, and you can write it and you cannot live it, right? I've seen both. I've seen agencies spend lots of time on it and just totally miss the mark. And I've seen agencies really hit the nail on the head and really live their value statement, mission statement. With those values, we look at, okay, what are your rituals? How do you interact with each other? How do you treat each other? What are your agency rituals? Your symbols, and these symbols could be things like, what's your logo? What are your colors? What's your uniform look like? And then there's rules and expectations that go along with these values that are really belief systems, right? So what are your rules and expectations? Do you follow a guideline that you call a rule? And do you deliver the expectation and follow through? So with Bob, it sounds like that expectation really was never there, right? It was really never truly delivered to Bob. And if it had been delivered in the past, it was one of those things where, hey, Bob, can you just add a little bit more to your narrative? And there was never any follow through with Bob. There was no true rule and expectation. There was no true consequence to Bob evolving into a longer narrative and essentially better clinical quality when it comes to outward facing. So with Bob, this is a behavior thing. So he's got the value system, he's followed the ritual, symbols, rules, and expectations at ABC, and then he's got this behavior that's resulted in it. And I guarantee if you have a Bob, you have many Bobs, right? That Bob's not going to be the only Bob, all right? There's going to be many Bobs there. This is a behavior thing. So when we look at this, we look at, okay, how can I change the behavior and where does this come back to? And it all really comes back to organizational culture. And we need to go back and look at, okay, do we have a mission statement and value statement? Are we following this and how are we doing that? And that's where the clinical improvement begins. And then once we start to follow this value system and start to enforce rules, and that sounds really, I don't like the words I just used, but we want to follow through on expectations, okay? If we start following through, we're going to eventually see the behavior change. And really, it also comes back to, do you have a good relationship with Bob? And can you tell a story to Bob that's going to resonate with Bob? You have to have that relationship with Bob. Build your relationship and then tell your story. So Doug, I would love to hear your take on this. So what are your thoughts on organizational culture and clinical documentation?
Oh man, I was loving everything you were just saying. Bet that was so insightful, Andrea. That was great. The only thing I would add to that is it's also how we model, how leaders, and I don't mean managers or people who are at the high, anyone who has the capacity to inspire others is a leader. And any of us at whatever title we hold is a leader. And leaders who send the wrong message, right? And particularly those who are in positions of responsibility. One example I like to give when I do documentation training is if the billing department comes to the operations department and says, look, we're having real problems with crews getting signatures. We can't bill these. They sit on the desk for a month while we send forms out to the patient. Sometimes the patients don't return them. There's all this revenue, and I don't care if you're volunteer, paid, whatever your services status is, the people who, if you're paid, you need money for payroll. If you're volunteer, the people who sell us trucks and equipment don't volunteer that, right? So we need revenue no matter what our organization status is. And, if we then take that information and at the next staff meeting or the operational in-service meeting, we say, all right, everybody sit down, pay attention. All right, the pain in the butt people in the billing department told me to tell you to do a better job of getting signatures. So consider yourselves told. Now let's talk about the new protocol, right? So the message we just sent is, I don't think this is important. You probably shouldn't worry about it either, right? Because it's not just the billing offices or the billing company's problem. It is the organizational problem. And the messages we send, both verbal and nonverbal. Okay, we're here to talk about documentation. Kill me, right? So whether it's verbal or nonverbal, those are pieces of culture that get transmitted around the organization and that send the message of how a staff person or volunteer, anybody should look at documentation in that organization. And if at all times we reinforce that this is a part of being an EMS professional, no matter your pay grade, that writing legally defensible, clinically accurate, compliant patient care records is a fundamental component of being an EMS practitioner. And that is the expectation we reinforce here. You got my attention, right? So that's the culture, and that you hit it right on the head. And that's the only addendum I would add to that. It's how we model those expectations when we come to documentation.
Excellent. Yeah, I love that. Yeah, our frontline supervisors or FTOs and everybody around us, if they're doing a great job in modeling it, it's just going to spread. So you don't have to be in an administrative position to be an influencer or a leader. So yes, thank you, Doug. And so a couple things just to kind of add to what we were just discussing. I just want to kind of hit these points home, and Doug touched on some of these as well. But our clinical documentation comes back to our beliefs and values, whether we realize it or not. Delivering the expectation is extremely important, and doing it in a succinct and professional way where we're passionate about it and we really want to make that change and spend some time on it. And the work environment, which I touched on earlier when we were talking about timeliness, setting your personnel up to be able to do great clinical documentation is important. Give them the time, give them a decent laptop to be able to do this. I was having a conversation with a crew member the other day, just the other day, about how his workstation really mattered to him. And it was really important. He was working as an echo paramedic. He was working on his own, and it was really important that he had a good workstation. So these are little things that we want to be sure we're tuned into. And then getting feedback. People say like, oh, if you get quality improvement feedback, it's not going to matter. Like, you can send messages all day and it's not going to matter. And the truth of the matter is, it does matter. I have yet to work in an environment where I've gotten feedback and not taken it seriously in one way, shape, or form. It does impact me. If someone reads my narrative and finds something I missed, I want to know about it. I want to hear about how I'm doing. If I nailed it on the head and it looks great, I want to hear about that too. Like, oh, great, I'm doing a great job. We've got to do more feedback. And I understand our hair is on fire and we're really busy, but feedback is so important. Don't discount it. It does matter. And if I have some innovative ideas I can talk with you offline about. I've done a lot of innovative things during my career around this. So if you want some ideas on how to implement, I'm sure Doug has some ideas too on how to implement programs around feedback that can be really fun and motivational. There are ways to do it. And then training and education, that's why we're here tonight. That's why we did this webinar, is we wanted to provide some really good training and education. We really tried to not make it dry because we realize this is a dry topic. So we, try to have fun with it, try to take small bites out of it, and try to deliver some really good in-house training and education around it. Don't do it once every 20 years, just in new employee orientation. Revisit this concept. And the last thing is storytelling. We have to be able to talk to our personnel about the story behind why. If we don't deliver the why, they are not going to get on the bandwagon. Our why is what drives us at work. So if you need Bob to change his narrative, we really need to have that relationship with Bob and to storytell with Bob in a way that makes sense to Bob. Why do I have to change this? Explaining it and telling the why. Storytelling is really important here. So really quickly, I got 1 minute. Okay, nearing the end here, I found this really neat study. It was about body-worn cameras. And what they did is they took 10 paramedics, they sent them into a simulated man-down call, and they had them wear the cameras during the call. They had them write the narrative after the simulated call. Then they reviewed the camera footage with each of these paramedics, and there were 71 revisions. 7 minor, 51 moderate, and 13 major. So what is really interesting here is the take-home message is we can be the most observant paramedic, but we are all having blind spots on a call. It could be that our adrenaline is pumping. It could be that we didn't look around the room. It could be that this was an agitated patient and we were focused on one thing. And the take-home message with the body cameras is that body camera saw everything, right? It had that whole view the whole time. And that's why these paramedics were going back and making these modifications. And again, our brains block out information really to save us, right? It's a survival tactic on a call. So we may have blocked sights and sounds that body camera, when you're in a lower state, you're going to see those and you're going to want to make changes. So I thought that was really interesting, just to kind of highlight, like, we're not going to catch everything, and documentation isn't necessarily going to be pristine each time. But just keeping in mind and highlighting, we all have blind spots. We're going to miss things on calls. And we know that when our partner says, did you see the guy with the knife standing in the corner? And you're like, no. How did you? There was a guy in the corner with the knife. How did you not see that? Well, you were hyper focused on that patient. It really can happen. So back to our take-home message here, poor clinical documentation. So you're going to increase your liability. You can decrease your revenue. The negative industry image, remember, people are reading these reports. This is your outward facing level of being able to convey what went on in a professional way. When people read a report that's 2 sentences long with misspellings and all lowercase letters, it just doesn't look good, okay? Keep that in mind. People do look at your reports. And the last thing is, let's not make our patients vulnerable. They are relying on us for payment. They are relying on us for life-saving interventions. Let's do the right thing and really invest in our patient care reports. So it is the top of the hour at 7 p.m. Doug, I can't thank you enough for joining me. I really appreciate this. Do you have any last words for our audience before we start to wrap up?
No, just thank you for having me. It was a lot of fun.
Oh, thanks so much for hopping on. And yeah, I look forward to chatting with you in September or hopefully sooner. All right, so bye, Doug. So the QA box, let's see, I think we already answered that. So I'm going to, while you guys are still online, I'm going to stop recording.